Question 1. A patient receiving IV heparin has an APTT of 110 seconds. Therapeutic is 60 to 80. What is the priority nursing action? A. Increase infusion rate. B. Stop infusion and notify provider. C. Administer protamine sulfate immediately. D. Recheck APTT in 6 hours. Answer: B. Stop infusion and notify provider. Rationale: an APTT of 110 is supratherapeutic, high bleeding risk. The infusion must be stopped immediately. Protamine may be ordered, but the nurse does not independently administer it without a prescription. Question 2. A patient on regular insulin IV infusion develops diaphoresis in confusion. Glucose is 42 milligrams per deciliter. What is the first action? A. Increase insulin rate. B. Stop insulin infusion. C. Give IM glucagon. D. Administer IV dextrose. Answer: B. Stop insulin infusion. Rationale: remove the cause first, stop the insulin, then treat hypoglycemia, IV dextrose if IV access present. Priority is preventing further glucose drop. Question 3. A nurse prepares to give potassium chloride 40 milliequivalents IV push for K plus of 3.0. What is the correct action? A. Administer slowly over 5 minutes. B. Dilute in 50 milliliters NS and push. C. Clarify order immediately. D. Give IM instead. Answer: C. Clarify order immediately. Rationale: IV potassium is never given IV push. It must be diluted and infused via pump. IV push KCl can cause fatal arrhythmias. Question 4. A patient receiving morphine IV becomes difficult to arouse with RR 7 per minute. What is the priority? A. Apply oxygen. B. Administer naloxone. C. Call rapid response. D. Stimulate the patient. Answer: B. Administer naloxone. Rationale: RR less than 8 equals opioid-induced respiratory depression. Naloxone reverses effects. Airway support follows, but reversal is immediate priority. Question 5. A patient on warfarin has INR 6.2 without bleeding. What is expected order? A. Continue dose. B. Administer vitamin K. C. Start heparin. D. Give aspirin. Answer: B. Administer vitamin K. Rationale: INR greater than 5 significantly increases bleeding risk. Vitamin K reverses warfarin effects. Question 6. Which electrolyte imbalance increases risk of digoxin toxicity? A. Hypernatremia. B. Hypokalemia. C. Hypercalcemia. D. Hyponatremia. Answer: B. Hypokalemia. Rationale: low potassium increases digoxin binding at NAK-ATPS to toxicity, arrhythmias, visual changes. Question 7. Before administering blood transfusion, the most critical safety step is A. Warm blood. B. Verify consent. C. Double-check patient ID with another nurse. D. Pre-medicate with antihistamine. Answer: C. Double-check patient ID with another nurse. Rationale: misidentification causes fatal hemolytic reactions. Independent verification is mandatory. Question 8. A patient on IV magnesium sulfate develops absent deep tendon reflexes. What is priority? A. Continue infusion. B. Administer calcium gluconate. C. Increase infusion rate. D. Give potassium. Answer B. Administer calcium gluconate. Rationale: loss of reflexes indicates magnesium toxicity. Calcium gluconate is the antidote. Question 9. A patient receiving TPN has sudden dyspnea and chest pain after line disconnection. Suspected air embolism. What is immediate action? A. Place patient in high Fowler's. B. Clamp line and place in left lateral Trendelenburg. C. Remove catheter. D. Start CPR. Answer B. Clamp line and place in left lateral Trendelenburg. Rationale: this traps air in right atrium and prevents pulmonary circulation obstruction. Question 10. A patient on epinephrine infusion becomes hypertensive and tachycardic. What is priority? A. Stop infusion. B. Slow infusion rate. C. Administer beta blocker. D. Give fluids. Answer B. Slow infusion rate. Rationale: epinephrine is titratable. Adjust rate to target parameters. Do not abruptly stop unless severe instability. Question 11. A patient receiving IV vancomycin develops flushing of the face, neck, and chest with hypotension during infusion. What is the priority action? A. Stop infusion immediately. B. Slow the infusion rate. C. Administer epinephrine. D. Document and continue. Answer A. Stop infusion immediately. Rationale: Redman syndrome equals slow infusion, but flushing plus hypotension equals stop infusion first, then restart at slower rate once stable. Question 12. A patient on IV unfractionated heparin has platelets drop from 220,000 to 90,000. What is the priority? A. Continue infusion. B. Reduce dose. C. Stop heparin immediately. D. Administer aspirin. Answer C. Stop heparin immediately. Rationale: suspect heparin-induced thrombocytopenia, HIT. Stop heparin to prevent thrombosis. Do not give platelets unless bleeding. Question 13. A patient prescribed insulin glargine asks if it can be mixed with regular insulin. What is correct response? A. Yes, in same syringe. B. Yes, if drawn first. C. No, never mix glargine. D. Only in emergency. Answer C. No, never mix glargine. Rationale: glargine is long-acting and must not be mixed. Mixing alters its absorption profile. Question 14. A patient on IV nitroprusside develops confusion and metabolic acidosis. What is suspected? A. Hyperkalemia. B. Cyanide toxicity. C. Renal failure. D. Hypoglycemia. Answer B. Cyanide toxicity. Rationale: nitroprusside metabolizes into cyanide. Toxicity presents with metabolic acidosis and neurological changes. Question 15. Which finding requires holding metoprolol? A. BP 150/90. B. HR 52 BPM. C. Headache. D. RR 18. Answer B. HR 52 BPM. Rationale: beta blockers lower heart rate. HR less than 60 is typically a hold parameter unless otherwise ordered. Question 16. A patient on IV morphine PCA becomes increasingly drowsy. SpO2 90%, RR 10. What is first action? A. Call provider. B. Administer naloxone. C. Stop PCA infusion. D. Increase oxygen. Answer C. Stop PCA infusion. Rationale: remove the source of respiratory depression first, then administer naloxone if respiratory compromise continues. Question 17. A patient receiving IV potassium 10 MEq per hour reports burning at the IV site. What is priority? A. Reassure patient. B. Slow rate slightly. C. Assess IV site immediately. D. Apply warm compress. Answer: C. Assess IV site immediately. Rationale: potassium is vesicant-like and irritating. Infiltration can cause tissue necrosis. Check patency. Question 18. A patient on warfarin is prescribed trimethoprim sulfamethoxazole. What is concern? A. Decreased INR. B. No interaction. C. Increased bleeding risk. D. Hypertension. Answer: C. Increased bleeding risk. Rationale: TMP-SMX increases warfarin effect, elevated INR, bleeding. Question 19. A patient receiving IV labetalol for hypertensive crisis suddenly becomes bradycardic and hypotensive. What is first action? A. Stop infusion. B. Increase infusion. C. Give IV fluids. D. Give epinephrine. Answer: A. Stop infusion. Rationale: remove causative agent first. Labetalol can cause excessive beta blockade. Question 20. A patient on digoxin reports seeing yellow halos. What is priority? A. Document finding. B. Administer next dose. C. Check digoxin level. D. Give potassium supplement. Answer: C. Check digoxin level. Rationale: yellow vision, xanthopsia, is classic digoxin toxicity. Hold dose and assess serum level. Question 21. A patient receiving IV amiodarone develops hypotension during the loading dose. What is the priority action? A. Stop the infusion immediately. B. Slow the infusion rate. C. Administer atropine. D. Give IV fluids bolus first. Answer: B. Slow the infusion rate. Rationale: rapid IV amiodarone can cause vasodilation and hypotension. First action is to slow the rate. Stopping completely is reserved for severe instability. Question 24. A patient on continuous insulin infusion for DKA has blood glucose 210 milligrams per deciliter. What is the priority adjustment? A. Stop insulin. B. Add dextrose to IV fluids. C. Increase insulin rate. D. Switch to subcutaneous insulin. Answer: B. Add dextrose to IV fluids. Rationale: in DKA, insulin continues until anion gap closes. Once glucose less than 250, add dextrose to prevent hypoglycemia while continuing insulin. Question 24. A patient receiving IV hydromorphone becomes unresponsive with pinpoint pupils and RR6/min. What is the priority? A. Call rapid response. B. Administer naloxone. C. Provide oxygen only. D. Stimulate patient. Answer: B. Administer naloxone. Rationale: classic opioid overdose. Respiratory depression with meiosis. Naloxone is immediate reversal agent. Question 24. A patient prescribed enoxaparin has spinal anesthesia scheduled. What is the major concern? A. Renal toxicity. B. Spinal hematoma. C. Hypoglycemia. D. Hypertension. Answer: B. Spinal hematoma. Rationale: LMWH increases risk of epidural or spinal hematoma, possible paralysis. Timing of dose is critical. Question 25. Before administering IV potassium 40 milliequivalents in 100 milliliters NS, what is essential? A. Ensure patient can swallow. B. Confirm urine output. C. Check blood glucose. D. Give with food. Answer. B. Confirm urine output. Potassium must not be given if patient is oliguric or anuric, risk of fatal hyperkalemia. Question 26. A patient on IV alteplase for stroke develops sudden severe headache. What is the priority? A. Continue infusion. B. Stop infusion immediately. C. Lower head of bed. D. Give aspirin. Answer. B. Stop infusion immediately. Sudden headache suggests intracranial hemorrhage. TPA must be stopped immediately. Question 27. A patient on dopamine infusion via peripheral IV reports pain and blanching at site. What is priority? A. Slow infusion. B. Remove IV. C. Stop infusion and infiltrate with phentylamine. D. Apply cold compress. Answer. C. Stop infusion and infiltrate with phentylamine. Dopamine extravasation causes tissue necrosis. Phentylamine is the antidote to prevent ischemic injury. Question 30. A patient on warfarin is started on IV heparin. When should heparin be discontinued? A. When INR is therapeutic, 2 to 3. B. After 24 hours. C. When PT normalizes. D. Immediately. Answer. A. When INR is therapeutic, 2 to 3. Heparin bridge continues until warfarin becomes therapeutic. Question 39. A patient receiving IV magnesium sulfate has RR8 min. What is priority? A. Continue infusion. B. Administer calcium gluconate. C. Give naloxone. D. Increase oxygen only. Answer. B. Administer calcium gluconate. Respiratory depression indicates magnesium toxicity. Calcium gluconate reverses it. Question 40. A patient on IV fentanyl infusion is mechanically ventilated. What parameter is most important to monitor? A. Bowel sounds. B. Pain score. C. Respiratory rate and sedation level. D. Urine color. Answer. C. Respiratory rate and sedation level. Fentanyl is a potent opioid. Oversedation and respiratory depression are primary safety risks. Question 31. A patient on IV norepinephrine via peripheral line develops cool, pale fingers on that extremity. What is the priority? A. Apply warm compress. B. Elevate arm. C. Stop infusion and assess site immediately. D. Increase infusion rate. Answer. C. Stop infusion and assess site immediately. Rationale: norepinephrine extravasation causes severe vasoconstriction and tissue necrosis. Stop infusion immediately. Antidote is phentolamine. Question 32. A patient receiving IV heparin has new onset flank pain and hematuria. What is priority? A. Increase IV fluids. B. Stop heparin infusion. C. Administer vitamin K. D. Check blood pressure only. Answer. B. Stop heparin infusion. Rationale: signs of active bleeding. Remove anticoagulant source first. Protamine may be ordered. Question 33. A patient on insulin NPH and regular insulin mixed in same syringe. Which is drawn first? A. NPH first. B. Regular first. C. Either order. D. Depends on dose. Answer. B. Regular first. Rationale: clear before cloudy. Prevents contaminating regular insulin with intermediate-acting insulin. Question 35. A patient prescribed IV morphine reports itching but stable vitals. What is the likely cause? A. Anaphylaxis. B. Histamine release. C. Toxic overdose. D. Withdrawal. Answer. B. Histamine release. Rationale: Morphine causes histamine-mediated pruritus. If no hypotension or airway issues, it's not anaphylaxis. Question 35. A patient receiving IV potassium has peaked T waves on ECG. What is priority? A. Continue infusion. B. Stop potassium infusion. C. Give insulin. D. Administer sodium bicarbonate. Answer. B. Stop potassium infusion. Rationale? Peaked T waves indicate hyperkalemia. Continuing potassium could trigger lethal arrhythmia. Question 36. A patient on warfarin has dark, tarry stools. What is priority? A. Document finding. B. Check INR. C. Hold warfarin and notify provider. D. Increase fiber intake. Answer. C. Hold warfarin and notify provider. Rationale? Melena equals GI bleeding. Stop anticoagulant immediately. Question 37. A patient on IV midazolam infusion becomes hypotensive. What is first action? A. Increase rate. B. Stop or decrease infusion. C. Administer naloxone. D. Give potassium. Answer. B. Stop or decrease infusion. Rationale: benzodiazepines can cause hypotension, especially in critically ill patients. Remove or reduce cause first. Question 38. A patient receiving IV calcium gluconate complains of burning at site. What is priority? A. Continue infusion. B. Assess IV site for infiltration. C. Increase rate. D. Apply cold pack without checking. Answer. B. Assess IV site for infiltration. Rationale: calcium is highly irritating. Extravasation can cause tissue necrosis. Question 39. A patient on continuous heparin infusion has APTT below therapeutic range. What is expected action? A. Stop infusion. B. Increase infusion rate per protocol. C. Give vitamin K. D. Hold next dose. Answer. B. Increase infusion rate per protocol. Rationale: subtherapeutic APTT increases clot risk. Heparin is titrated per protocol. Question 40. A patient receiving IV propofol infusion develops triglycerides of 600 milligrams per deciliter. What is concern? A. Kidney failure. B. Propofol infusion syndrome. C. Hypernatremia. D. Hypoglycemia. Answer. B. Propofol infusion syndrome. Rationale: propofol is a lipid-based. Elevated triglycerides increase risk of propofol infusion syndrome, a life-threatening complication. Question 41. A patient on IV alteplase (TPA) begins bleeding from IV sites and gums. What is the priority action? A. Apply pressure and continue infusion. B. Stop infusion immediately. C. Administer heparin. D. Lower head of bed. Answer. B. Stop infusion immediately. Rationale: active bleeding during thrombolytic therapy is an emergency. Stop the drug immediately to reduce hemorrhage risk. Question 42. A patient receiving IV epinephrine for anaphylaxis develops chest pain and ST elevation. What is priority? A. Continue infusion. B. Stop infusion and notify provider. C. Give aspirin immediately. D. Increase rate. Answer. B. Stop infusion and notify provider. Rationale: epinephrine can cause coronary vasospasm and myocardial ischemia. Remove cause first. Question 43. A patient on IV vancomycin has trough level above therapeutic range. What is the safest action? A. Give next dose as scheduled. B. Hold next dose and notify provider. C. Increase infusion rate. D. Administer with food. Answer. B. Hold next dose and notify provider. Rationale: elevated trough increases nephrotoxicity and ototoxicity risk. Hold and clarify. Question 44. A patient on continuous IV heparin is scheduled for surgery in 4 hours. What is priority? A. Continue infusion. B. Stop heparin per protocol before surgery. C. Give vitamin K. D. Start warfarin. Answer: B. Stop heparin per protocol before surgery. Rationale: heparin increases bleeding risk during surgery, typically stopped 4 to 6 hours prior. Question 45. A patient on insulin infusion has a potassium level of 3.1 milliequivalents per liter. What is priority? A. Increase insulin rate. B. Stop insulin and give potassium. C. Continue insulin only. D. Give sodium bicarbonate. Answer: B. Stop insulin and give potassium. Rationale: insulin shifts potassium intracellularly, worsening hypokalemia. Severe hypokalemia increases arrhythmia risk. Question 46. A patient receiving IV dopamine for shock develops new arrhythmias. What is priority? A. Increase infusion. B. Stop or decrease infusion. C. Give digoxin. D. Ignore unless BP drops. Answer: B. Stop or decrease infusion. Rationale: dopamine increases myocardial oxygen demand and can trigger arrhythmias. Question 47. A patient on warfarin falls and hits their head but feels fine. What is priority? A. Observe only. B. Check INR next week. C. Immediate evaluation for intracranial bleed. D. Give vitamin C. Answer: C. Immediate evaluation for intracranial bleed. Rationale: anticoagulated patients can develop delayed intracranial hemorrhage even without symptoms. Question 48. A patient receiving IV potassium chloride has serum potassium 5.8 milliequivalents per liter. What is priority? A. Continue infusion. B. Stop potassium immediately. C. Increase rate. D. Add magnesium. Answer: B. Stop potassium immediately. Rationale: hyperkalemia can cause lethal arrhythmias. Never continue potassium when level is elevated. Question 49. A patient on IV morphine becomes hypotensive. BP 80/50. What is first action? A. Increase morphine. B. Stop morphine infusion. C. Give naloxone automatically. Or D. Document only. Answer: B. Stop morphine infusion. Rationale: morphine causes vasodilation and hypotension. Remove source first. Reversal depends on respiratory status. Question 50. A patient receiving IV insulin has blood glucose drop from 450 to 120 milligrams per deciliter in 1 hour. What is the major concern? A. Hypotension. B. Cerebral edema. C. Hypernatremia. Or D. Renal failure. Answer: B. Cerebral edema. Rationale: rapid glucose shifts cause osmotic fluid shifts into brain cells, risking cerebral edema, especially in DKA management. That's how you handle high-alert medications. Not with fear, but with precision. These are the drugs that save lives and end them if you get careless. Insulin, heparin, potassium, opioids, vasopressors. No autopilot, no guessing, no shortcuts. Patient safety is not about memorizing antidotes. It's about recognizing early warning signs, stopping the harm fast, and thinking 2 steps ahead of the complication. If you survived all 50, you're not just studying nursing, you're thinking like a safe nurse. Stay sharp, stay accountable, protect your license, protect your patient. See you in the next clinical battle.